get better results. But we all have seen that we have moved from an era of neurolysis to an era of ablative therapies to an era of regenerative therapy. So in this regenerative era, we are not only treating the pain, we are treating the cause of pain, we are treating the root cause. What is the once we understand what is the extent of damage, when we understand what is the cause of the damage, we understand it, we map it, and then we treat it properly. So I would like help of regenerative therapy, we are something that we are challenging the surgical interventions. Most of our regenerative therapies will work for musculoskeletal conditions, which is mostly for degenerative conditions or traumatic conditions like in sports injuries or because of overuse injuries. So in such conditions where surgical interventions, major surgical replacements have played a very important role, now we are challenging those with the help of regenerative therapy. Plastics or medicine or dermatology or plastic. So till a decade after in a textbook of orthopedics, but now it's whole lot of its own speciality. So when we talk about regenerative therapy now, initially we were talking a lot about platelet-rich plasma and stem cells, but now we have a lot of cell-based or cell-based molecular therapies which have come. Even prolotherapy, viscosupplementation, everything can be included in this group of regenerative therapy. But by and large, I would like to talk about mostly about the platelet-rich plasma therapy. Growth factors from patient's own blood, origin, and according to the differentiation they go. So there are pluripotent. And of all these, the one which is very commonly used in musculoskeletal is the mesenchymal cells. So mesenchymal cells are nothing that is can differentiate into different cells like the osteoblast, chondroblast, and adipocytes in vitro, and they should have the expression of CD73, CD19, CD90, and CD105. So again, coming back to the literature, like I said, most of us sitting here are still new into this regenerative therapy and still platelet plasma and VMAC that we are commonly in conditions, and which they have any musculoskeletal condition, for example, knee osteoarthritis, lateral epicondylitis, plantar fasciitis, are small. These have definitely showed short-term and long-term efficacy in increasing the quality of life and giving a good outcome as compared to conventional therapies like hyaluronic acids and steroids. So this is again a study where they have used autologous platelet-rich plasma to increase, promote tendon repair. So we have in our institution going on a study on rotator cuff injury, where we have seen that the rotator cuff injury usually will heal with 2 or 3 sittings of PRP, but the healing usually does not occur in 1 or 2 months. So we have used a parameter of measuring the tear size with the help of ultrasound, and we have seen that there is improvement and decrease in the tear size over a period of 6 months to over 1 year. So when we talk about regenerative therapy and when we give this solution to the patient, we need to understand that this is not going to give us immediate relief. The immediate relief may come because of the anti-inflammatory property, but may not be up to the expectation of the patient. So first, as a physician, we need to understand that it is a slow and a steady process, and we need to counsel the patient and understand that it is going to take at least 6 months to 8 months for us to show any objective result in the patient. Again, this was a study where they have studied between PRP and steroid, and they have showed that PRP does have effect better than steroid. Even in the tendinosis, like I said, in tennis elbow, also in rotator cuff and ATFL injuries in ankle, there are results which have shown better results with PRP as compared to the conventional treatment. So these are the literature which we can go through. Now, just giving an overview of what is PRP and how we do it, just an overview for all the beginners sitting here. That, like I mentioned at the start of my lecture, there is lack of literature, and we have moved from an era where there was no FDA approval to now where we have FDA clearance and of course a few commercially available kits which are also into ICMR and FDA approval guidelines. So like I was saying, platelet is something which is like 2 to 8 times the concentration from its baseline, and it has more than 30 active bioactive proteins, which helps in healing, hemostasis, and most of when it comes in contact with a damaged tissue or a damaged cartilage, the activation will start, and then within 1 hour, the 95% of the growth factors will be secreted from PRP once it is injected. So when we talk about types of PRP, we have leukocyte poor, leukocyte rich, platelet rich fibrins, platelet rich, platelet poor fibrins. So all those things, there are multiple ways of preparing platelet and multiple ways of extracting leukocyte poor, leukocyte rich, and depending upon the condition the patient is suffering, we can use them. So what will be the mechanism? Because of the antimicrobial action, by promoting the healing fast, by regenerating the damaged tissue and restoring the function, the platelet is going to actually repair the damaged tissue, and we can correct the cause of the damage. So this is just a flow chart. There are various ways of preparing platelet, by a single centrifugation technique, by a double centrifugation technique. So usually what we prefer is doing a double centrifugation. So a very small quantity of blood, depending upon which commercially available kit you are using, you can, they have their own standards. According to that, you can prepare. Usually the first spin where the RBCs needs to settle down is done at a lower revolution for a lesser period of time. And then the second spin, which is the hard spin, where we extract the platelet-rich plasma, is done at a revolution little higher than the first spin for 10 to 12 minutes, depending upon the kit we are using. So again, how the variation in the platelet concentrate will differ. Even a small minute thing while doing platelet-rich plasma plays a very, very important role. For example, a very practical aspect is when you try to extract the blood, you make sure that you are taking with such a wide bore needle that there is no RBCs lysis happening, so there is no trauma happening to the RBCs. So the way you collect the blood, the quantity of blood and the quantity of plasma or not, but as an institutional protocol, we usually avoid doing this. PRP in pain medicine, like I said, any degenerative condition or any chronic tendinopathies because of overuse, underuse or trauma can be treated, can be repaired with the help of regenerative medicine. The most commonly that we do is with osteoarthritis of knee joint and other osteoarthritis of other joints as well. We have seen post-COVID patients of young patients coming with avian hip, as the number have increased. Then chronic tendinopathies like tennis elbow, golfer's elbow, then we have Achilles tendonitis, rotator cuff injuries, sports injuries, all those things we have seen that the results are definitely very, very good. Also in spine, in cases of annular tear, or also in degenerative condition of facet joint arthrosis or sacroiliac joint arthrosis, PRP is giving good results. But as compared to other musculoskeletal conditions, our results with spine is little less, but I'm sure we must be having a lot of physicians practicing PRP for spine who can give us good feedbacks about the spine interventions. But as compared to musculoskeletal, our results with spine is little less. Selection criteria of platelet-rich plasma is very, very important. The patient whom you're choosing to opt for this treatment is very, very important. Like I said, the counseling of the patient is very important because the results are not going to be very immediate. In 1 month or 2 months, we are not going to result. So if the patient is ready to take that, it's a slow process and it is going to take time. That patient is very important, because if the patient is not ready to accept that there won't be any immediate relief, then it would be very difficult. Patients where pain duration is of usually 3 to 6 months or longer, and they have been, and the diagnoses have been made with other investigations like MRI, X-rays and CT scans, the patient pursue an alternative therapy to surgical treatment. So selection of patient is very, very hope for a better results. Pre-procedure advice to stop NSAID platelets and do a complete blood picture, that is all commonly done. So again, the very most important thing in platelet-rich plasma getting us success is the factor that we don't assess the efficacy of platelet-rich plasma. First thing is we don't assess what is the damage, what is the extent of damage. Usually when a patient of knee joint comes, we think it is knee osteoarthritis. But what we fail to do is to understand how much is the damage inside the joint. So we do a ultrasound scanning for every patient coming to us in our clinic. We assess if there is any fluid in the joint, if there is an associated bursitis, if there is an associated tendinopathy, if there is a Baker cyst. So once we understand what is the damage and how much is the damage, then we prepare a protocol. Like I say, the condition is one, it is osteoarthritis of knee joint, but the patients present differently with different symptoms. So it is very important that we understand the damage and then opt for the treatment. Only then we can assess how good we are going, and then we can assess the efficacy of PRP. So we need to identify the pain generator in knee joint. Is it because of the cartilage loss, or the pain is more because of the meniscal injury, or is because of the ligaments or any other bursa, or because of accumulation of fluid? Again, the second very important point is doing an image-guided intervention. We have ultrasound, we have fluoroscopy. So it is very, very important that we do image-guided exactly at the site of damage so that we get better results. So how PRP works in osteoarthritis is by because we know that the cartilage does not have that ability to restore and self-repair. So using the anti-inflammatory property of platelet-rich plasma, and then it also prevents the further degeneration of the cartilage. It stimulates the leftover cartilage to regenerate, and it improves the internal environment of the joint and reduces the gene expression of inflammatory mediators in both the cartilage and the synovium, and that's how the PRP is going to help. One very important thing is, most of the cases we see of osteoarthritis, we always have meniscal degeneration associated with it, especially the medial meniscus, because that's where the whole weight will fall on. So when you don't address the meniscus degeneration, the results with PRP for osteoarthritis is less. So we have a study going on in our institution where we have separated 50 patients of osteoarthritis, treating only PRP for cartilage regrowth, and 50 patients where we also inject 0.5 ml to 1 ml of PRP for the meniscus. And the results, we see that there is a huge difference when we also address the meniscus. So you need to identify each and every structure, and meniscus and knee pain is something that we cannot fail to see. Again, for shoulder joint, we have glenohumeral and AC joint, and then rotator cuff injuries. Platelet-rich plasma works good, but again we need to understand. We need to do ultrasound scan, or by understanding if there is a presence of bursitis and what is the tear size. We can measure with ultrasound. Of course, there will be some subjective bias when we do all those things, but definitely it is going to give us objective finding where we can have our own records to understand whether this PRP is working or not. Like I said, avascular necrosis in young patients post-COVID, we are getting a lot of patients, and PRP yielding them good results. So in rotator cuff, in any tendinopathies, how the PRP is going to help is by forming a tendon to bone. It forms a layer of interface of cells, so that it helps in regenerating the damaged tissue. Later on, strengthening is very, very important, and so only PRP is not going to help. We also have to put the patient for a good rehab. Same applies for other tendinopathies like for tennis elbow, plantar fasciitis, Achilles tendon, all those things. There was a research where they have studied and showed that PRP definitely is going to work in cases for tendinopathies, and the short-term and the long-term results with the improvement in quality of life and the functional improvement is better. Large for PRP is because of the related non-invasive nature of the treatment and a well-established safety record. And the future of regenerative therapy definitely comes into sports medicines as well. Like I was saying, why we fail is because we have failed to assess the efficacy of PRP. There should be an objective and a subjective way of assessing. So we have different kinds of scoring system. Definitely has a good role in musculoskeletal conditions, in degenerative and chronic tendinopathies. But definitely the preparation and the injection technique is very, very important. We fail to explain the do's and don'ts to the patient. and above all belief in the speciality, because most of us sitting here does not believe that this speciality is going to yield results, because we don't have any tool where we assess the efficacy. So we all need to take it forward. So all those who are practicing, definitely we should opt a proper guideline, and everyone, we all can have our institutional protocol where we can assess how much this PRP is going to help our patients. Thank you so much.
Thank you, Meenal, for a very lucrative presentation. We'll take the questions in the end, so please there in the hall. And now I call the